Okay, so we're going to get started. Thank you for coming here early this morning to hear us talk about bipolar depression across the lifespan. This activity is supported from an educational grant from Synovian Pharmaceuticals. And first, I will be talking about diagnosis and treatment of bipolar depression in children and adolescents. And I'm Melissa Del Bello from the University of Cincinnati. And then Dr. Roger McIntyre will be talking about bipolar depression in adults, considerations for middle age and beyond. So our learning objectives for this morning are to describe the diagnosis and evidence-based treatments for bipolar depression in children and adolescents. We're going to formulate strategies to optimize diagnosis and management of bipolar depression in older patients, and we're going to discuss the significance of neurocognitive impairment in patients with bipolar disorder across the lifespan, including the impact of psychotropic medications. So with that, I will get started, and first, as I said, we're going to talk about diagnosis and treatment of bipolar depression in children and adolescents. Here are my disclosures. Okay, we're going to start with a case of Madison, who goes to see a psychiatrist, and she says, everything's my fault. My dad's upset because my grades are down. I keep thinking they'd be better off without me. And then the psychiatrist says, I'm pretty sure they disagree, Madison. One thing at a time. Why are your grades slipping? So Madison is a 16-year-old previously diagnosed with major depressive disorder and ADHD. She was unsuccessfully treated with methylphenidate and escitalopram for 2 months. So she's tearful, and she says, I don't know, it's just that lately I can't, concentrate. For the last couple of months, I haven't been sleeping. My mom complains that I never eat enough, and I'm tired all of the time. I used to love school, but now I don't enjoy much of anything. I feel like I'm always cranky. Do you think your family understands what you're going through? And Madison says, not really. A year ago, they stuck me in the hospital, and now I think they want to do it again. Tell me about the hospital, the prior hospitalization. How'd you end up there? Well, it was about a year ago, and I was only sleeping a few hours a night. I couldn't get along with anybody. My parents said I was talking too fast. I was always arguing, which I wasn't. That's what she said. They were starting the arguments. I couldn't help it. My thoughts were racing, and my mom found something I wrote in my journal, and they put me in the hospital because I talked about dying. So first we'll start off talking about bipolar depression and the presentation in children and adolescents, and then we'll talk about what treatment data we have about treating depression associated with bipolar disorder in children and adolescents. So most of you are aware that bipolar disorder in children and adolescents is the 4th leading cause of disability, and followed before that by schizophrenia, and before that by accidents and unipolar depression. But depressive symptoms in general are very disabling in children and adolescents, and because it can impair lifelong relationships, it can impair lifelong accomplishments in school, it has a lot of disability associated with it. Comorbidity in children and adolescents with bipolar disorder is the rule rather than the exception. Most common comorbidity is ADHD. Other common comorbidities, anxiety disorders, and depressive symptoms or diagnosis with severe major depressive disorder is very common at initial period of onset. But ADHD is very common in adolescence. It's more common than during adolescence. It's more common than during adulthood, and during prepubertal onset, it's even more common than during adolescence. So most of you also are aware that when you retrospectively ask adults with bipolar disorder, when was their age of onset, 50 to 60% will say that it's during childhood. Irritability is one of the earliest and most common features of early onset bipolar disorder, but irritability is like having a fever. It's not very specific. It doesn't really tell us what's going on. It just makes us suspicious that we need to figure out there's something going on when there's irritability that results in functional impairment. But it could be depression, it could be unipolar depression, it could be bipolar depression, it could be anxiety disorders, it could be an adjustment disorder. So it's not very specific. And so we really need to get the specific criteria for whatever diagnosis and screen for all diagnoses. Early onset bipolar is associated with a higher risk lifetime of completed suicides as well as suicide attempts. And bipolar depression and depressive periods associated with bipolar disorder is more common than mania in early onset patients. So what is depression associated with bipolar disorder? I think it's very important to take a minute to think about it. So cross-sectionally, when you see a patient with depression, a child or adolescent with depression, they can have a lifelong diagnosis of unipolar depression, or they can have a lifelong diagnosis that ends up being bipolar depression. Or retrospectively, if you get the diagnosis of depression at the time, you need to look for a retrospective diagnosis of a manic or hypomanic episode for bipolar 2. So it could be very hard to get that retrospective diagnosis and get the symptoms retrospectively from a child or adolescent. It's very important to talk to the family. It's very important to also ask about family history, which is a big clue about diagnoses. Currently, cross-sectionally, they will look like they have a unipolar major depressive episode. It's only when you retrospectively ask about the manic symptoms that you can get the diagnosis of bipolar depression. If they have a concurrent manic and depressive episode, that used to be called a mixed episode, and that was the most common presentation for children and adolescents. Now we call that a manic episode with mixed features. So when there's concurrent mania and depression, it actually defaults to a manic episode with depressive features. But the problem is that the depressive features can be just as severe and just as leading to functional impairment as a mixed episode was. When I see a patient with bipolar depression, that scares me the most. It is an episode that will last longer than a manic episode. It's an episode that takes the longest time to recover, and also is the time when they're most likely to attempt suicide. So that phase of the illness scares me. So just to summarize the epidemiology, for the majority of adults with bipolar disorder, they had their onset during childhood or adolescence of bipolar disorder. Early onset bipolar disorder is associated with higher comorbidity, higher long-term functional impairment, and depressive symptoms, whether it's part of unipolar depression or bipolar depression, are in the top 4 causes of disability among children and adolescents. So again, this is just long-term outcome. If you see a patient with depression and they have bipolar 1, bipolar 2, bipolar NOS, they have a worse outcome than those who present initially with a manic episode. So what are symptoms that you can mistake if you see a patient with depression? And you have to retrospectively get the diagnosis of a manic episode. So manic episode, as you know, can present also with irritability. And irritability in children and adolescents can also be part of a depressive episode. So it's important to try and figure out the other symptoms that come along with the diagnosis. But depressive episodes that are part of bipolar may be more difficult or are more difficult to determine cross-sectionally in children and adolescents because of the irritability. Sometimes kids with just irritability and the full constellation of depressive symptoms are diagnosed with bipolar disorder, or they're diagnosed with disruptive mood dysregulation disorder. So it's really important to look for the manic features, at the time and retrospectively. And the criteria for mania in children and adolescents are the same as they are for adults. The only difference in criteria for depression, as most of you are aware, is the irritability and also the appetite decrease. And there's not necessary weight loss as part of depressive criteria. It could be failure to maintain a normal weight or weight gain that's supposed to have. All kids grow and are supposed to gain weight. Okay, so suicidality is very common in children and adolescents with depression associated with bipolar disorder and bipolar disorder in general. And it doesn't matter if it's bipolar 1, bipolar not otherwise specified, or bipolar 2, but it's very common, and particularly when there's depressive symptoms. There's also more and more that we're learning about the neurophysiology of depression associated with bipolar disorder, and it does, in most cases, look a little bit different than unipolar depression in children and adolescents. The problem with doing some of these studies is that some of the children and adolescents who present with unipolar depression will end up having bipolar depression, and so you don't know lifelong if those children are going to end up being bipolar or end up having unipolar depression lifelong. So it's a little bit complicated to do some of these studies, but predominantly in hippocampus, right putamen, prefrontal, subcortical, limbic regions, spectroscopy data, fMRI data, and structural data show that there are differences in children who have bipolar depression versus children who have no psychiatric illness. And there is a difference between bipolar depression and bipolar mania, as well as bipolar depression and unipolar depression in children and adolescents. And predominantly, we see differences in areas of activation, but the direction of activation. So there's abnormalities in activation in the prefrontal cortex, particularly medial prefrontal cortex, in terms of resting state, fMRI, as well as neurometabolic abnormalities as demonstrated by spectroscopy. Okay, so just to summarize the diagnosis and presentation, irritability is a cardinal feature of depression. It's also a cardinal feature of mania, and it can be very confusing. And so you really need to look at the other symptoms that accompany the irritability. With depression, they may have a depressed mood, but they don't need to. With mania, they typically will have elation, expansive, euphoric mood in children and adolescents, even if they present with irritability. And it's very severe if they have bipolar depression. The long-term outcome is more severe than if they have unipolar depression, and they're more likely to have lifelong increased frequency of depressive symptoms. So that's kind of the phenomenology background. Now we're going to shift a little bit to, you've identified that they have bipolar depression, you've retrospectively gotten that manic episode, and cross-sectionally they're appearing depressed, kind of like Madison in our case. And now you're stuck with, well, okay, how do we treat this patient that's in front of us? And there are a lot more FDA-approved pharmacologic interventions for acute mania. We now have 6 agents approved for children and adolescents with acute mania. Depression associated with bipolar disorder has been an unmet need, as well as long-term maintenance studies. Right now, we do have 2 agents that have been approved for acute bipolar depression in children and adolescents. The combination of olanzapine, fluoxetine, Symbyax. Most of us as child psychiatrists don't use a lot of Symbyax per se. We'll use olanzapine and fluoxetine if we're going to use that combination and make our own. Lorazepam is the first monotherapy that has been approved this year for bipolar depression in children and adolescents. And then long-term, we have lithium, which there's not a ton of evidence to suggest it's efficacious long-term, but it was grandfathered in by the FDA. We're now getting some data. And then aripiprazole, because of their long-term data. So first we'll talk about a little bit about non-pharmacologic treatments, and then we'll look at what role do antidepressants play. We'll talk about the open label data with lithium and Lamotrigine, and then we'll get into the second generation antipsychotics, and we'll talk about the data with Quetiapine, OFC, and lorazepam. So I think it's very important to say that pharmacologic interventions are not the only treatment for bipolar depression. They need to be used adjunctively with non-pharmacologic interventions. And while therapy, as most of us know, is not very effective for bipolar mania, for bipolar depression, there's evidence that as adjunctive treatment, psychosocial interventions such as multifamily psychoeducational group therapy and David Miklowitz's family-focused therapy can be very effective. And that involves treatment of the whole family. And that seems to be more effective or more preventative for depressive symptoms in children and adolescents as adjunctive treatment. And of course, it's helpful to have children and adolescents mood chart at whatever level they would like to mood chart. It's important to educate children and adolescents with bipolar disorder about their risk for developing substance use disorders, which in adolescents is about 40 to 50%. And typically the onset is of bipolar first and then of substance use disorders. So there's that window of opportunity that it's important to do education, and then getting accurate information to the child as well as to their family and their school as well. So with that said, what role do antidepressants play in the treatment of children and adolescents with bipolar depression? Well, again, it's very important to figure out, do they have unipolar depression or do they have depression associated with bipolar? This is an old study, but one of the only studies that we have in children and adolescents. And this study suggests that SSRIs are actually the most effective treatment at the time for treating bipolar depression. However, they are also the treatment that leads to the greatest probability of relapse into mania. So if you leave them on board too long, that child will have the greatest risk of having a recurrent manic episode. So SSRIs may be effective, but as adjunctive treatment, and this is mostly as adjunctive treatment, you have to use them with great caution. This is a study that we did actually looking prospectively at children who have parents with bipolar disorder who present with anxiety or depressive disorders. And it shows that if you treat those children who don't have manic symptoms at the time with antidepressants, the younger the age, the more likely they are to have negative adverse effects, like really negative, like end up in the hospital, psychosis, suicidality. And so you can see that in this high-risk population, even if they don't have manic symptoms at the time, but present with unipolar depression and anxiety disorders, if they're prepubescent, they have almost 180 to 100% chance of having a bad reaction to antidepressant monotherapy, whereas the older you get, if you're in your 20s or 18 to 20, there's really minimal chance that you're going to have an adverse reaction with a family history. And it may be that those kids that are treated earlier, those kids' prepubertal depression is a risk factor by itself for having a lifelong diagnosis of bipolar disorder, but that along with a family history of bipolar puts you at very high risk for having a bad reaction to antidepressants. Similarly, in a study that was done, a small study, looking at negative reactions to children and adolescents who present with bipolar disorder, and this is bipolar, all different types of bipolar disorder, bipolar spectrum illnesses, you can see that if you're treated with an antidepressant, you're more at risk for having a negative reaction. So up to 80% of bipolar 1 children and adolescents who are treated with an antidepressant will have a negative reaction, including about 30% who will have new onset suicidality. So The jury's still out in a controlled fashion on antidepressants, but retrospective data suggests that although it may be effective for treating depressive symptoms, you run the risk of having long-term bad outcome, including suicidality, psychosis, hospitalization with antidepressants. There have been 2 open-label studies in treating children and adolescents with bipolar depression, a study with Lamotrigine. Lamotrigine was shown to decrease depressive symptoms. In pediatric bipolar depression studies, the main outcome measure is typically a childhood depression rating scale, and that is a measure of childhood depressive symptoms. It's a clinician-rated instrument. Typically, to get into most studies, you have to have around a 40 or a 45. In this study, they started out with a 60. Lamotrigine, of course, needs to be titrated very slowly, but this is an open-label study, and at the end, the average CDRS score was about 30. This is a study with Lithium, and you can see Lithium has an initial drop in CDRS score, but then it kind of maintains at about 40, and unfortunately, that's what you need to get into most studies, is a 40. And so it has some effect. This is monotherapy, I should have said. And so for this 6-week study, it had some effect. And lithium, I should say, was maximized to a therapeutic blood level above 1 in this study. So with Lamotrigine and lithium, limited data to suggest maybe there's some positive effect. Side effects are typically what we see. Of course, with Lamotrigine, you have to be careful. The nice thing about Lamotrigine is it's pretty well established to be weight neutral, and you do need to worry about not only the rash, Stevens-Johnson's associated, if you titrate more quickly, particularly in younger kids, but also if you use it concomitantly with oral contraceptive pills. And we know adolescent girls with bipolar disorder are at high risk for becoming pregnant. That's been pretty well demonstrated. So those are kind of the limitations of using Lamotrigine. So there have been 2 studies with Quetiapine in bipolar depression in children and adolescents, and one study was a small study, 2-site study that we did at University of Cincinnati and Stanford. And this study, it was an 8-week study, and either with bipolar, you had to have bipolar 1 depression, and you can see that at beginning, most of the kids were around 50 on the CDRS, and at end, they were around 30, and both groups. So you can say that Quetiapine was no more effective than placebo, or both placebo and Quetiapine reduced depressive symptoms. But regardless, Quetiapine was no more effective than placebo. That was a relatively small study of about 38 children and adolescents. This was the much larger study of hundreds of, about 200 children and adolescents with bipolar 1 or bipolar 2 depression. This was with Quetiapine XR. And again, these studies were done because the studies in adults showed that Quetiapine was highly effective. But you can see here the same exact findings as we found in a much smaller sample, is that Quetiapine was no more effective than placebo during the course of this study. Side effects are similar to what was seen with other Quetiapine studies, sedation being common, headaches, dizziness, but again, no big surprises. So then there was a study with the Olanzapine Fluoxetine combination, and this was in children and adolescents with bipolar depression, ages 10 to 17, and it is an 8-week study, and there was a 2-to-1 randomization, so you had twice the chance of being on Olanzapine Fluoxetine combination versus placebo. It was flexible dosing within a certain range. And you can see here that starting at week 1, there was greater reduction in depressive symptoms, significantly greater than in placebo. That reduction increased and lasted to week 8. You can see the number needed to treat. So how many people do you need to treat to get one person better? Was 6. The number needed to harm in terms of weight gain, so the definition was gaining more than 7% of your baseline body weight, was 3. So you treated 3 people, 1 person gained more than 7% of their baseline body weight within the 8-week study. So fairly significant. Effective, but fairly significant weight gain. No big surprises here either in terms of adverse effects. Weight gain was the top side effect. Other side effects, increased appetite that go along with it, some sedation. What you can see here is, again, that 50% of patients gained more than 7% of their baseline body weight. And you can see that there were also other metabolic side effects. Fasting triglycerides, cholesterol had a slight bump in this short-term study. So in the OFC group, there was a 4.4 kilogram weight gain versus the placebo group where the weight gain was 0.5 kilograms. And BMI increased over 1.5 points in the OFC group. So unfortunately, it's effective, but the weight gain was fairly significant in a short-term study. So that brings us to the last study we'll be discussing, which is the most recent study, a placebo-controlled study of lurasidone in children and adolescents with bipolar depression. This study was a 6-week study, a 1-to-1 randomization of about 300 kids. Again, flexible dosing of lurasidone from 20 milligrams as a starting dose. You could titrate up to 80 milligrams per day. The average dose in the short-term study was 30 milligrams, so very low compared to what the max you can go to in the short-term study. And then there's a long-term open-label study if you finish the initial 6 weeks that lasted up to 2 years of open-label lurasidone, and we'll present some of the initial findings from that study. So again, about 300 kids in this study, all with bipolar I depression. So the results from the double-blind study, looking at the main outcome measure of children's depression rating scale scores, and you can see here that starting at week 2, there was a significant reduction in CDR-S scores in the lurasidone group versus the placebo group. The effect size was medium, about 0.5, and it increased throughout the 6 weeks of the study and maintained separation from placebo. So there was a significant greater reduction in the lurasidone group versus the placebo group. As I mentioned, the median dose was 30 milligrams. And then when you look at the open label, the 2-year outcome data, you can see that first of all, there was very high retention in this study compared to a lot of other studies that last 2 years. And in the acute study, there was very good retention both in the lurasidone and the placebo groups. And so very high retention probably gives you a better chance of success. And long-term, as you can see, the CDR-S scores were maintained at the lower level. And so the depressive symptoms for those who stayed on lurasidone maintained. The median dose in the long-term study was about 55 milligrams per day. So when you look at the rates of response and remission by the time in the study, you can see that at almost 2 years, that there's still about 86% remitters out of all the people who respond. So the people aren't just getting a little bit better. Those who are responding are getting much better, is the point of that. Side effects in terms of tolerability, headaches, nausea, somnolence, long-term. Some reported weight increase, although we'll look at that in a second. And those are the main side effects that were greater in the open label treatment. Now, what I think in the short-term treatment, the number that gained more than 7% of their body weight versus placebo, it was greater. It was about 5% in the placebo versus about 4% in the lurasidone group. So in the short term, there was no difference in terms of weight gain or those who gained significant amount of weight. But you can see this is exciting because these are 2-year data. And when you control, obviously kids grow and they're supposed to gain some weight over 2 years. These were, adolescents, and so you would hope from age 10 up they're growing and gaining some weight. Over a 2-year period, the projected anticipated weight gain in this group was no greater than in any other group that is the same age who wasn't treated with any psychotropic medication. So when the patients were treated, the actual treatment with lorazepam, because there's no placebo control, you just have to look at the expected weight gain in that age range. And you can see long-term over the 2 years, there was no difference. As far as the metabolic parameters at 2 years, very little sign that there's any significant difference. Slight bump in the triglycerides, but it's only 6 points. And actually decrease in cholesterol. And there was, at the initial 6-week study, there was a slightly greater increase in prolactin in the girls versus the boys, but not clinically significant. Here you can see in the 2-year open label data, there was no difference between lorazepam and change in what you'd expect in prolactin levels in boys or girls. Okay, so in conclusion, the majority of adults with bipolar disorder will have their onset during childhood or adolescence. And the most common presentation and the most common impairing symptoms are associated with depressive symptoms. Early onset bipolar is associated with highest risk of suicidality. And there are very few, compared to bipolar mania, there are very few bipolar depression treatment studies in children and adolescents with bipolar disorder. And now we have 2 agents that are FDA approved for this age range. Olanzapine, fluoxetine combination, effective, very effective, but can lead to pretty significant metabolic problems. Lorazepam is the first monotherapy, and generally in the acute phase as well as the 2-year phase appears to be very well tolerated. So with that, I will end, and people are walking around. If people have questions, we'll save that for the end, but people are collecting them, so please hand in your questions if anyone has any. I'll stop at that point. Do you want to introduce yourself? Go ahead.
Okay, well, thank you, Melissa. Good morning, everybody. We're going to pick up on the theme, the motif of this set of presentations being the phenotypic variability or the phenotypic heterogeneity on the surface in terms of the phenomenology, but also the underlying neurobiology and possibly treatment of bipolar across the age span. And as I was sitting here in my chair, I was sort of just thinking about how we've really pivoted in how we think about what's occurring at the neurobiologic level in bipolar disorder during the past decade. We really have moved towards a more coherent, comprehensive conceptualization of the pathoetiology of bipolar disorder that would posit that there are 2 processes that are occurring in these patients, both neurodevelopmental alterations as well as neurodegenerative alterations. And those alterations are occurring in some cases simultaneously. And obviously, that's of academic interest, and it has translational importance as we begin to think about what are the objectives of the interventions that we're trying to provide. And the way I think about it is we are trying to put people back onto a normal, that is an age, sex, education, etc., normal trajectory. And what Melissa has described is clearly a complex phenotype childhood bipolar disorder, clearly an example of neurodevelopmental alteration. I'm going to take us to the other end of the chronological age, that being in the older age. And as I'm thinking about this, in some ways it's a bit of fake news, calling my presentation older age bipolar, or maybe it's misleading, because if you are 10, 20, 30 years of age, by definition you have a premature aging disease. It's called bipolar disorder if that's your diagnosis. And that's been a very interesting observation. If we look at bipolar at the molecular level, if we look at the pattern of comorbidity, that is age-related concurrent conditions like cardiovascular disease, if you look at premature cognitive impairment or premature mortality, taken together, all of this indicates that bipolar is a premature aging condition. Notwithstanding, I'm going to be conventional, and my presentation is going to focus on individuals over the age of 60 or perhaps now over the age of 50 who have bipolar disorder. And what does that really mean for us clinically? What does it mean for us neurobiologically? And what does it mean for us therapeutically? And all of us in the room are not unaware of the aging demographic, and all of us are seeing more people and a higher proportion of people over the age of 50, or certainly 45 to 50, who have bipolar disorder. The usual disclosures, they're in the handouts. Here's the graphic, and this graphic is a graphic cartoon that I think many could relate to. Here's a gentleman seeing his physician, Dr. Walsh. I've not been sleeping well. Gary gets very cranky at night. He's been arguing, so obviously someone who's irritable. This is someone who's in his mid to late 50s, retired from the IT sector, and has had a working diagnosis of depression, treated with an SSRI going back. And when the history is obtained, what we find out from the partner that's joined him for his meeting here is he's had times of distractibility. There's been maybe some depressive symptoms in the past, and that's been acknowledged by this person. In other words, this person is in mid to late 50s, has had a working diagnosis of depression, but a more detailed, more granular characterization of the phenomenology indicates that perhaps depression may not be sufficiently explanatory. It then goes on to talk about, well, Gary, in fact, has had depressive symptoms that are occurring. This cognitive dysfunction or cognitive complaints that Gary's having may not be simply a function of getting older. The discussion takes place further. Gary, in fact, has been labeled by his friends as, in quotes, manic, based on the fact that he's been someone full of energy and indefatigable, someone who, in fact, doesn't sleep perhaps as much as he should be, up in the middle of the night doing all kinds of things. Has been really an achiever. And so, like many things in life, we're often pre-contemplative, and perhaps now that we're contemplating the possibility that maybe depression's not the right diagnosis has come forward. And so the patient spends more time with the healthcare provider with a more detailed look into some of these symptoms, only to find out there's examples of impulsivity, maybe some spending excesses, along with the irritability, the excess energy, and the increase in overall activity. Okay, so let's say a few words, if we can, just to set the stage a little bit. Epidemiology is the familiar starting point. And there's two ways to think about the epidemiology of bipolar in later age. First of all, let's define later age. And I have to be very careful in defining old age. I don't want to insult anyone in the room, including myself. So I would like to define it as over the age of 90, but I can't define it that way. Older age has really been conventionally defined at age 60 in this area, this so-called space. There's actually reasons to make it a little earlier. In other words, the age at 50. Now, the purpose of going earlier to 50, defining older age bipolar, is by no means an effort to try and increase the market share. That's certainly not the reason. The reason is that what we're noticing is that seems to be an inflection point vis-a-vis looking at some phenomenological differences, neurobiologic differences, and maybe some of the illness trajectory differences. Let's just throw some numbers or percentages around. It's often stated that about 10 to 15% of people who have bipolar disorder declare the first episode after the age of 60. That's been a highly replicated percentage, 10 to 15%. But I think a more really relevant percentage is if you look at the totality of the bipolar population, including people who grow older. They started their illness at age 20, 25, 30, who grow older with bipolar. What's the percentage or what's the proportion? It's around 25%. So 1 in 4 people with bipolar disorder are over the age of 50, and the projection is that will increase to almost half of our patients with bipolar over the next 10 to 15 years. So 25% is the answer to the MCQ, if that was a question on that particular point. Now, when you start to look at people who have bipolar disorder in older age, and you compare them to people who have bipolar declaring at age 20, 25, there's lots of similarities. Yogi Berra said that my son and I are very similar and our similarities are very different. And so when you look at the bipolar in older age, there are, in fact, some differences. And I'm going to come back to this throughout the presentation. You see this one call out vis-a-vis the presence of concurrent cerebrovascular pathology. Now, when we're making the diagnosis of bipolar, it is a clinical diagnosis. We gather a clinical history based on cross-section, based on past history and family history. And taken together, if you juxtapose the individual who has older age bipolar, that is first declaration, versus those who have a more conventional declaration, age 20-25, on average, the older age person with bipolar is less likely to have a positive family history of bipolar disorder. They are more likely to have concurrent cerebrovascular pathology. So that alone suggests that there may be some different pathways mechanistically into older age bipolar. Now, one of the exciting aspects about how we think about the disease model in bipolar broadly, kids, adults, older age, is that the underlying circuitry in the brain is abnormal. That is, the underlying circuits that connect cortical and subcortical structures. We now bandy about language like coherence. The functional interconnectivity is abnormal. And in the laboratory setting, that's looked at with an approach called diffusion tensor imaging. The language is FA, fractional anisotropy. All that means in English is this is a way of looking at the coherence, the interconnectivity of the circuitry. And when you look at people who have bipolar, they have a white matter disease. They have an interconnectivity disease. They have an alteration in the structure and function of this underlying circuitry as indicated by reductions in FA. What am I really saying? What I'm saying is that the bipolar disorder illness generally, and certainly in older age, is a circuitry disease, and this circuitry alteration is certainly highly replicated in older age individuals with bipolar. Depressive symptoms and depressive episodes are the polarity first in younger people with bipolar. They're also the polarity first in people who have older age bipolar. In other words, the first declaration of the illness is depression. Moreover, longitudinally, looking at the symptom structure, what is also revealed is that depressive symptoms and episodes dominate the course. And that's been observed by many, many groups. This is one group from Holland looking at the index polarity being depression, and that has been the predominant polarity across time. So just to take a sort of a time out, what I would say is that there alone is the clarion call that for every patient over the age of 50, either first or recurrent episode of depression, he or she should be screened questions around bipolar disorder, just like the gentleman in our cartoon. Now, older age bipolar disorder is a depression predominant presentation, not dissimilar from someone who's younger in life, chronologic life. The other point I wanted to really underscore is cognitive impairment. Bipolar disorder is a condition of profound cognitive impairment, and our older age individuals are certainly no exception. Going back to something I mentioned earlier, that being the premature aging that we now believe is a process in bipolar, that is, these individuals have molecular and cellular evidence of aging, but they also have premature cognitive impairment, accelerated cognitive impairment. And I suspect if we did a survey around the room, I would have many people here today, many colleagues like me, who've had patients in your practice in their early 50s, maybe even younger, who now have mild cognitive impairment or even Alzheimer's disease in their 50s. And I've seen that tragedy more than I would have ever believed once I started this profession many years ago. So we know we have accelerated cognitive aging in older age bipolar, and we also have a higher rate of dementing disorders broadly. So what's the message? Depressive symptoms and or admixed with cognitive impairment is the clarion call to be screening for bipolarity. And by the way, cognitive impairment presents in its obvious ways. Patients subjectively complain of diminished cognitive dexterity, flexibility, function, etc. But it also can present as agitation, irritability, and not infrequently delirium. When I was a fellow in pharmacology, I worked at a nursing home for 2 years. On the weekends, they used to work me to death. They used to ask me to see like 80 patients on a weekend. It was unbelievable. But anyways, I remember seeing so many patients who were delirious, and they were delirious and agitated for a variety of reasons, but one of the reasons was they were cognitively impaired, and many of these people had bipolar. So the diagnosis is arrived at clinically. The tactic of arriving at the diagnosis in older age bipolar, that is first episode, is no different than it would be in someone who's 30 or someone who's 15. You take a careful history, look at phenomenology. I mentioned the overrepresentation of depression and cognitive impairment. I'm also going to add psychosis. So we all know that psychosis affects depression and manic symptoms. And when you look at the age of bipolar disorder, it appears that people who are chronologically younger and chronologically older have a greater susceptibility to psychosis. So psychosis more common in the patients Melissa would see versus someone who's 30, and certainly more common in someone who's 65 with bipolar disorder. The other part I wanted to talk about is the mixed features, or this mixed phenotype that we see in patients. There is a view that as you get older with bipolar and or as bipolar declares itself in later life, yes, more depression, but also more anxious agitation. Much more of this anger outburst, much more of the irritability being seen in these patients. Let's in fact look at other probabilistic factors. The age at onset. Well, I already said that people who have bipolar disorder in older age, if that's when it starts, well, that is by definition an older age at onset. But again, the great majority of older age bipolar are people who've grown older with bipolar. And in the gentleman in the cartoon, looking at the age at onset obviously is relevant. In fact, I always say if there was 2 questions I could ask a patient, I'm only allowed to ask 2 questions to determine whether I think the person's bipolar. Really 2 questions I want to ask outside of current phenomenology is what was the age at onset and how many episodes have you had since this illness began? Clearly family history is relevant, but as I said, family history positive for bipolar is a lot lower in people who have first episode after the age of 50. Now, I don't want to forget patterns of comorbidity. We'll say a few words about that in a moment, but comorbidity affects bipolar more than any other psychiatric disorder, perhaps in part because of the aging process, but for a variety of reasons that we could speculate. People who first have the bipolar present over the age of 50 may have a lower rate of substance use disorders, may have a lower rate of psychiatric morbidity, still higher than the general population, but lower than their bipolar counterparts at age 20, 25. But I don't want to imply they're off any kind of hook because the medical morbidity in this population is extraordinary. Now, for me to say that bipolar in old age is impairing functioning is a bit of a axiomatic, self-evident statement. We know that's by definition the case. But what I've been quite struck by in my patients that I've seen grow old with bipolar or first episode after age 50 is how quickly the functional trajectory goes down. In other words, yes, by definition they're impaired, but talking about people well-educated in many cases, functioning quite well, and really deteriorate very, very quickly. And that's just something I've impressionistically observed in this particular area. So medical comorbidity in bipolar is a significant problem. You all know that. Pop quiz, what is the most common medical comorbidity in bipolar disorder today across the age band? It is obesity and related morbidity. And by the way, we actually believe that the underlying neurobiology of bipolar is shared with obesity and related conditions. Older age bipolar, first episode, and certainly growing older with it, these folks have a much higher rate of cardiovascular and cerebrovascular disease. Someone might be sitting there thinking, well, doesn't that go with the territory getting older? Absolutely it does, but when you age adjust it, it's significantly higher indeed. And over half of these people are either pre-diabetic or diabetic. And that's relevant because with each episode of bipolar disorder that a person experiences in their life, there's a proportionate increase in the risk of all-cause dementia, including but not limited to Alzheimer's disease. So clearly that's relevant, and what's so interesting is that we know that 80% of people who do have Alzheimer's disease in older age are insulin resistant. So clearly the diabetes risk in this patient population itself carries with it hazards, and as you get older, there's other hazards like Alzheimer's and cardiovascular-related dementias. Psychiatric comorbidities, one of these observations in the literature for a long time that the one-year prevalences or the one-year estimated prevalences of some psychiatric conditions may be a little less than what we would expect in a bipolar individual at age 25, but again, higher than age-matched controls. And obviously it's going to depend on where you work and where you live. One point I wanted to highlight is the issue of suicide. Suicide is clearly not a comorbidity. Suicide is a tragic endpoint for too many people. And we do know that the risk of suicide in bipolar is the highest of all psychiatric populations. The risk of suicide completion is highest within 10 years of observable characteristics of bipolar beginning. Said differently, if you are like most people, bipolar beginning in your teenage years, 20s, it's that first 10 years that's really the highest risk, which, by the way, is so critical because we keep hearing it takes 10 to 15 years to make the right diagnosis. So that's clearly a window of opportunity that we've got to try and do better at. But the point I wanted to leave you with here is that the suicide risk remains elevated throughout life. This is some data from colleagues in Denmark showing, in fact, that there is a higher risk of suicide throughout the entire lifespan. It is the so-called risk ratio or the hazard ratio, it depends which how you do this, is a little lower relative to younger people, but still elevated. So in other words, the risk of suicide never returns to, in quotes, population norms. It remains elevated even in older age. A few words about cognition. This is something that my team in Toronto has been very interested in major depression and bipolar. I emphasize 2 points. It's an accelerated cognitive decline in older age bipolar. That speaks to neurodegenerative processes that are accelerated. There's also a higher rate of dementing disorders. Now, they sound the same, accelerated cognitive decline and a higher rate of dementing disorders. They're overlapping. They may not be identical, or said differently, it may not be inevitable that the accelerated cognitive decline, it's a fait accompli, you end up becoming demented. So there's overlapping phenotypes here. But our message is we don't want accelerated cognitive decline. This article is making the case that the coping style of people who have bipolar in older age, well, it's diminished. And what these investigators ascertained is that the coping style, when it was more passive, less functional, was in many ways explained by cognitive impairment. Said differently, what this is really saying in English is that the patient that we're seeing, this gentleman who's 58, he's not really functioning very well interpersonally. His coping style is obviously not adaptive. And the ability to be resilient, the ability to cope with day-to-day stressors, job, personal, family, etc., these coping strategies are impaired in large part because of the cognitive dysfunction. In fact, when you conduct what's called a mediational analysis, and a mediational analysis in simple language means how does the symptoms mediate the outcome? How does it mediate function? What we find is this convergent finding that in the area of bipolar disorder, there are 2 principal mediators of functional outcome: depressive symptoms and cognitive impairment. Said differently, if our wish is to put people back on trajectory, back on normal function, which every patient wants, we've got to do better at detecting, diagnosing, treating, managing depression and the cognitive impairment of these conditions, bipolar and depression. A friend of mine over in Denmark, Lars Kessing, has done a lot of work on dementia. I find this to be disquieting, that with each episode of bipolarity, there's a monotonic, there's a proportionate increase in the declaration of Alzheimer's, vascular, all-cause dementia. And that's been replicated across multiple studies. It's been meta-analyzed. As I said, I've had the experience, I'm not alone, I'm sure, in this room, of having patients that I've known since I was a resident in psychiatry who are now in their 50s and now they're suffering from dementia. I would never have thought when I started as a psychiatrist that I'd be signing forms for my patients at age 55, 56 to put them in the nursing homes because of dementia. This is obviously very alarming. And so the question is, what can we be doing about this? We'll come back to dementia in a moment, but let's just talk broadly around cognition. We don't have any FDA-approved treatment for cognition in bipolar. In fact, the only agent in the psychotropics of mood disorders that the FDA currently has recognized as having some degree of cognitive enhancement is Fluoxetine in the area of major depressive disorder, where that's now in the product label for that agent. But in the bipolar area, we know that there are many different drugs that we're looking at that really give us reasons to believe could be pro-cognitive. I think I should start off by saying we have lots of drugs in bipolar that are anti-cognitive, that patients are often taking, including benzodiazepines, anticonvulsants in many cases can be anti-cognitive. Last week in Canada, we legalized marijuana. The whole country is hypomanic right now. And so clearly, despite what our patients believe, smoking big ice cream cone-sized marijuana joints is anti-cognitive, and that needs to be clearly communicated. So clearly, we have a lot of anti-cognitive drugs, and of course, booze is never to be forgotten as well. But when it comes, in fact, to lithium treatment, which is kind of interesting, lithium has been shown to have anti-dementia properties. It seems to reduce the elevated hazard for Alzheimer's disease in adults with bipolar. So notice how I said that. Bipolars have elevated hazards, and the lithium brings it back down to the normal rate in the general population. And there's an elegant story how lithium inhibits amyloid deposition. It also reduces hyperphosphorylation of tau, two markers that are implicated at the scene of the crime in Alzheimer's disease in one way or the other. But the curious aspect about lithium is that it does cause cognitive impairment in younger people and older people. Is one of the more common complaints. Just to give you a little sampling of some of the ways we're experimentally looking at this, we've done studies giving patients intranasal insulin who are non-diabetics to try and improve their cognitive abilities. And this is based on a model that insulin dysregulation is a critical mediator of cognitive decline and bipolarity. We've shown pro-cognitive effects. This is not really a treatment that's ready for the prime time. I wouldn't recommend it. But there is a way, there is a poly pill that can increase insulin sensitivity. It is called exercise, and a pill not many people like to swallow. And that is a treatment that, that people are looking at, that is the pro-cognitive effects of exercise, is it mediated through insulin signaling? Now, we come to meetings like this to hear about new science. We also want to hear about new treatments you can take back to your office on Monday morning. This is more for your interest. This is liraglutide. This is a drug called Victoza. This is a diabetes drug. This is a weight loss drug. It's at the drugstore, FDA indicated for weight loss and diabetes. We've done studies with this drug attempting to demonstrate that it's pro-cognitive in bipolar disorder and depression, and this is a proof of the concept. By no means does this convince the jury beyond a reasonable doubt, but it's at least a starting point in the concept that this drug, which is a diabetes drug, weight loss drug, is also pro-cognitive at doses of 1.8 to 3 milligrams in adults that we see with bipolar and depression. The data for antipsychotics has been very mixed. Conventional antipsychotics in bipolar clearly are not pro-cognitive. I would actually say that based on my read of the literature, there's more anti-cognitive signals with older first-generation antipsychotics. Within the second-generation category, What you're seeing on the slide is healthy controls versus antipsychotic versus antipsychotic. And you're going to see, depends on the study, one drug does better than the other. A couple of points, certainly the sedating effects of quetiapine have been a problem with respect to processing speed and cognitive tasks. Some suggestions that there may be some benefits in some patient populations, but quite frankly, have not been rigorously studied with the view to really answer the question, is there a direct, independent, and pro-cognitive effect? Some crossover work looking at antipsychotics in the area of cognition, giving some suggestion of benefit, but I'm going to be ruthless and say, what we really need is more rigor looking at euthymic patients, or what we describe as a path analysis, a way wherein we can sift out whether the benefits, if there are benefits, are direct independent effects of the drug and not some kind of epiphenomenon as a consequence of the patient just simply getting better. The depression's getting better, their hypomania is getting better. And I don't want to get lost in the weeds of methodology, but that's critical. And it's a small study, but it's an important, I think, concept study insofar as this was a study in younger people with bipolar disorder. They're euthymic, so they're not depressed or manic, and they were randomly assigned to a placebo or lorazepam, and the rationale was based similarly to what we thought with vortioxetine. Vortioxetine has effects on 5-HT7 and other molecular targets that we think could be pro-cognitive, and lorazepam is different, but it does share in common a 5-HT7 target, and there's other targets indeed. And based on that, based on also some previous preclinical work and other clinical work with lorazepam, it was looked at in euthymic bipolar patients as an adjunctive treatment. And this study gave us some suggestion that there may be some pro-cognitive effect to beat placebo at improving an overall sort of cognitive battery measure in adults who have bipolar. So we do not believe that all atypicals are similar when it comes to depression, and we certainly don't believe that they're all similar when it comes to cognition. Some are clearly anti-cognitive, and maybe some might be pro-cognitive indeed. Bipolar depression, let's go back to that focus. Again, cognition and depression are the foci, and we just don't have really good science around depression and old age specifically. We don't have randomized controlled trials in the elderly dedicated to bipolar depression only. Here in Florida, by the way, is the best guidelines for bipolar disorder, most updated, circa 2018, MedicaidMentalHealth.org. You can download them, and in there's guideline as to how to select and sequence treatments for bipolar broadly, including older age. We know non-adherence in this population is a significant problem across the age band, but because of perhaps accelerated cognitive decline, there could be an additional reason why we see more non-adherence or non-concordance in our older patients with bipolar. And the other part to the picture is the histograms at the bottom here is the polypharmacy of bipolarity. Polypharmacy is not something anyone's striving towards, but we often end up there by default. That in itself I don't think is a crime in and of itself, but certainly irrational polypharmacy would be a crime, and we see too much irrational polypharmacy. And I think that one of the better ways to treat depression and cognitive impairment in bipolar is the taketh away the benzos, taketh away some of the anticonvulsants and some of the other drugs that they're taking to try and reduce the burden on brain and give them more appropriate evidence-based and or guideline-suggested treatments. So what are the treatments we have pharmacologically? You can see the list at the bottom. I would love to show you a very long list. This is a fairly short list. And you can see, in fact, we have some evidence for the atypicals, lorazepam and quetiapine in older people with bipolar depression, and really not as much evidence for some of the other agents that are listed there below. Lamotrigine we heard about in children. In the older age has been looked at. This is open label data. This is an old drug, been with us a long time. Lamotrigine was derived from an anti-malaria drug called pyrimethamine. And we've been using it a lot for the depressive symptoms and episodes of bipolarity. And this data suggests that it could have some benefit in older age bipolar patients. And this is a post hoc analysis of a Quetiapine data set looking at people who were 55 to 65, 2 doses, 300 and 600 milligrams, more dropouts at the 600 milligram than there was the 300 milligram, but a suggestion of some benefit in attenuating depressive symptoms in people in this particular age group. Similarly, there was a post hoc analysis done of short and longer term out to 6 months data, people at 55 years plus with lurasidone in bipolar depression. We heard about the data in children and adolescents, I should say. I think we all know that this agent's approved in the adults as well, but this is confined to 55 older, and indeed we see a attenuation of depressive symptoms in this population. And just to be clear, that bipolar cognition study I showed you earlier was in a euthymic group. So that pro-cognitive effect was independent of the antidepressant effect. Just like the young people, we've not seen metabolic disruption and or changes in body weight parameters with lurasidone. And that's important because you all know by now that obesity is anti-cognitive. Diabetes is anti-cognitive. Dyslipidemia is anti-cognitive. So you know it as being cardiotoxic. Think of it also as cognitively toxic. And that's something we clearly need to consider, that is health above the neck as well as below the neck. ECT, in my view, is grotesquely underutilized. I think it remains the most effective treatment for bipolar depression, quite frankly. I appreciate there's stigma, there's access, availability, costs, and things of that nature. But let's not, I think any presentation on bipolar depression, or for that matter, bipolar disorder, doesn't talk to ECT is missing an important slide. And so this is something that has shown some benefit as well in people who are in their older age. So a couple of points. We're talking about neurodevelopmental, neurodegenerative. Older age bipolar disorder is, in fact, the tip of the proverbial iceberg insofar it does reflect a premature aging condition. And when we talked about the phenomenology, wanted to underscore the depression predominance, the cognitive acceleration, the cognitive impairment. Clarion call loud and clear for screening, and we talked about various treatments. Folks, thank you very much.
So the question is, why do we say bipolar 1 with depression? Doesn't bipolar 1 always include depression? And my answer to that would be, by DSM-5, all you need is a manic episode to have the diagnosis of bipolar 1. Now, having said that, in children and adolescents and adults as well, I would say probably 85 to 90% will have a depressive episode as well as a manic episode. But for DSM-5 definition, diagnosis of bipolar 1, you don't need a depressive episode. So it's important to differentiate. Is it a manic episode with depressed features? Is it, or with mixed features? Is it a manic episode, or is it a depressed episode? To know how to guide the correct treatment. And then there's several questions about why not use Lamictal for children with bipolar disorder. As you may or may not know, there is a study that shows it may be effective for preventing recurrent episodes, particularly in adolescents, but there's no evidence to suggest for acute mania in children and adolescents is effective. And you saw the open label study to suggest for acute bipolar depression that it may in open label studies be effective. Now, lamotrigine is not, as I mentioned, without risk. There's the risk of Stevens-Johnson's that is particularly present in younger patients, and the rate of titration needs to be slow. So to reach a therapeutic dose, which generally in children and adolescents is somewhere around 100 or above, 150 or above, it takes time. So if you have somebody who's acutely depressed with bipolar disorder, it's not a quick solution. And then we also talked about the complications with a lot of adolescent girls with bipolar disorder are on oral contraceptive pills, and because of lamotrigine's interaction, it's not all that easy to use with those adolescent girls. Do you want to take one?
Okay, so I'll take a couple questions here. A lot on cognition. Are patients with bipolar who are not medicated in older age, do they still evince cognitive problems? And the answer is yes. Cognitive impairment in some cases is a consequence of medication like benzodiazepines, but cognitive impairment is part of the illness. Another question relates to ECT and cognition. ECT clearly causes autobiographical memory deficits that can persist, but, and this surprises some people, most people who receive ECT, cognition improves, if you look at the total battery of cognition. But yes, deficits in memory are a significant problem. And one last one on cognition, which is really important here. If you detect, diagnose, and treat bipolar earlier, will that prevent late-age cognitive impairment? There's reasons to believe that is the case if that lithium literature is true. I think it probably is true, that if you can get patients diagnosed and treated early, at least with lithium, there's reasons to believe that you could forestall, that is, you could delay and or reduce the elevated hazard of Alzheimer's. Will that apply to other psychotropic agents? I don't know the answer to that, but my working hypothesis would be yes, of course, depending on the agent.
Okay. Yep,
go ahead. Yep.
Okay. So there's a question about lithium and why don't we commonly use lithium in children and adolescents is kind of the gist of the question, because of the evidence in adults that it may reduce risk of suicide. There's not a whole lot of evidence to suggest, particularly for bipolar depression or for maintenance, that lithium is effective. For bipolar mania, it may be effective, particularly the evidence from a group in Canada that suggests, particularly if you have a family history of bipolar disorder in response to lithium, it may be effective in that population. But as Dr. McIntyre mentioned, children and adolescents who take lithium complain a lot of the cognitive slowing. We hear that commonly in children and adolescents, so I was surprised to see the data with Alzheimer's. And then acne worsening is another side effect that we hear a lot of complaints about. We don't have great evidence to support its efficacy, but lithium, I agree. I think it's probably underused in children and adolescents with bipolar disorder, particularly those who have a family history of lithium response. And then I can kind of go through a few of these questions, specific detailed questions about Latuda, the dose range for children and adolescents. Well, the data suggests that from 20 to 80 milligrams, those are the dose range that's been approved for bipolar depression in children and adolescents. And, generally speaking, 20 to 40, most of the kids in the acute phase were on 20 to 40, 60-something%. So that seems to be a fairly effective dose, at least acutely. And then there's a question about using Latuda for bipolar depression with eating disorders. Probably not ideal, because you do need to eat to get Latuda absorbed, and we haven't talked much about that, but you have to have at least 350 calories. So if you have an adolescent with an eating disorder, it may be very difficult to get the Latuda absorbed because they're restricting what their intake is.
Okay, a couple of questions here, specifics around some medications. My thoughts on Abilify, I'm going to fill in the blanks. I presume that means around depression and cognition in older age bipolar. We don't have any RCT evidence, that is randomized controlled trials with a placebo, that would indicate that Abilify would be antidepressant in bipolar disorder, and I don't know of any evidence of procognition of Abilify in bipolar disorder. With respect to memantine, interesting question. There's a larger interest in glutamate and glutamate targeting in psychiatry, with ketamine being one of the leading, or S-ketamine, one of the leading agents in this area. Interestingly enough, memantine has proven not to be an antidepressant in bipolar, and has turned out not to beat placebo in major depressive disorder. So all roads may lead to glutamate, it seems these days, but not all glutamatergic drugs are necessarily antidepressant, and that gets into a very granular, weeds-level conversation about differences pharmacodynamically between agents that engage glutamatergic receptors and systems. And then one final one here, just on the actual treatment. Oh, here it was here. Namenda, donepezil. Again, similar comments. What's interesting is that there has been an interest, for example, in using acetylcholine-based agents in depression and bipolar with a view that we could reduce the cognitive decline and or improve cognition overall. The evidence supporting that that is the case has been underwhelming, and if that was not disappointing enough, the story worsens because you exacerbate depression. And this goes back decades where it's been known in pharmacology that the enhancement of acetylcholine seems to engender depressive symptomatology. So this is the trade-off. You're not getting a lot in terms of procognition, and you're worsening depression. So that's clearly not a calculus that is favorable for using those agents for now.
I'm going to take liberty to actually ask you a question about metformin. Is there any evidence on cognition with metformin?
It's a great question. There are actually mixed evidence for metformin in mixed populations, e.g. diabetes and other groups. People have been looking at this in Parkinson's, for example. I have not seen I've not seen a metformin study in bipolar where the primary aim was cognition. People have typically given 500 to 2,000 milligrams of metformin for weight loss. Right. And interestingly enough, we know that weight loss is procognitive. But the question really is does metformin, like insulin or maybe liraglutide, does it have a direct procognitive effect at cellular, targets, et cetera? I don't think I know the answer to that.
Be interesting to find out. Okay, so along those lines of cognitive impairment and bipolar disorder, there's a question about treating bipolar with comorbid ADHD and treatment in adolescents. And generally, we take this strategy of stabilizing mood first, and then most of the time that can enhance cognition, or what we call ADHD. We still need about a third of the time to 40% of the time to actually treat the comorbid ADHD or the comorbid inattention. I think the general strategy is to treat the bipolar and the mood state, stabilize the mood first, and then consider using a stimulant or with the lowest dose possible. And generally, the preference is methylphenidate-based versus Adderall or Vyvanse, or not methylphenidate-based, or medications that affect more neuroreceptors, because that may increase the chance of having adverse effects or mood destabilization from a stimulant.
Here's a question, my final question I have here on lithium. And as people get older, they tend to have diabetes, heart disease, cerebrovascular disease. Would lithium really be appropriate in older age patients? And my answer to the question is, as a guiding principle, lithium would certainly be an appropriate agent in an older person with bipolar disorder. Then the next sentence would be, assuming that they have appropriate features that would be responsive to lithium. So this would be someone who's got a stable episodic bipolar illness. Unfortunately, a large percentage of people with bipolar older age have rapid cycling, mixed chronic illness, high rates of medical concurrent conditions, and that would reduce, in my mind, the role of lithium. It doesn't take it off the list, but it reduces its role. We cannot walk away from the anti-suicide literature from lithium. It's very powerful. You can't sort of walk away from that anti-dementia literature. That's pretty interesting. But yes, clearly, in fact, lithium in elderly patients, there could be some reasons why you would not use it, for the reasons I mentioned. And the second part to the question is, how do I handle patients who've been on lithium, done well for years, and their kidney begins to deteriorate? So they have creeping creatinines. Everyone in the room's faced this many, many times. Over the years, I think I've tried everything I could possibly do for this. I'm going to get right to the answer. I end up stopping lithium, and that's unfortunate. And switching to something else, and then crossing my fingers that it works. You know.
Yes, I've definitely, even in children and adolescents, encountered the elevated bump in creatinine, and it's challenging, especially when they've responded, if they've responded. So there's a question about using imaging in general to diagnose children and adolescents with bipolar disorder. And, there are, in groups, specific changes, groups of bipolar adolescents, but not specific. We don't have a specific biomarker that we can say this child or adolescent with this fMRI finding will have bipolar disorder. We're getting closer than we originally were, and maybe predicting if they present with depression, who's most likely to react poorly to antidepressants, or who's more likely to respond to specific medications. I think that's where we'll see the biggest effect of neuroimaging studies first. And then there's a question about differentiating using neuroimaging or brain changes to differentiate between bipolar and other diagnoses. There's a question about PTSD or ADHD. We don't, again, there are groups of patients. There are findings like ADHD, children and adolescents generally have more striatal findings, abnormalities, and don't have amygdala abnormalities. The most common finding in children and adolescents with bipolar disorder, in general, bipolar mania, bipolar depression, euthymic, is amygdala abnormalities in terms of function and structure, as well as prefrontal amygdala connectivity using DTI and other imaging. And those findings are not present. So PTSD, there's a lot of evidence that hippocampal abnormalities are present. They may be present in specific states of bipolar, but not, generally speaking, not during bipolar mania. So can't be used to diagnose anything at this point. And then there's a question about shouldn't we just be diagnosing children and adolescents with bipolar disorder with ADHD and ODD as opposed to bipolar mania? And so I don't believe ODD exists, so that's my bias. I think children and adolescents, ODD is basically saying they're irritable. And kids are not innately irritable to the point where they're seeing us. And so there's typically, again, irritability is like a fever. There's something wrong. We just need to figure out what it is. So ODD doesn't really help us. There's no treatment studies for kids with just ODD. For ADHD, if you don't treat the mood dysregulation, and there is irritability associated with ADHD, but that's not the mood dysregulation we see with bipolar disorder or unipolar depression. And so the treatment is very different. Kids who have bipolar disorder or major depressive disorder, they don't respond to just monotherapy with stimulants, which would be the treatment for ADHD. And then there's questions about weight gain, and the question basically is, does diet and exercise help with SGAs and weight gain? And of course we heard that, yes, diet and exercise is the solution to everything, but getting people to adhere to that is difficult. And yes, it is a great solution to some problems that we see with these medications, but it's very difficult to, when people are craving carbs or not really feeling, they're depressed, they're not feeling motivated to do anything, it's very hard to get at least children and adolescents to exercise.